So today we'll do cervical cancer, and this is for epidemiology. So cervical cancer is the fourth most common cause of cancer death between ages 35 to 44 years of age. Okay, which type is most frequent? Squamous cell carcinoma is most frequent and adenocarcinoma is less frequent. Okay, now the risk factors of cervical cancer is human papillomavirus, especially the stains 16, 18, and 45. Okay, immunosuppression, because when the patient has immunosuppression, they might get infected by human papillomavirus, and then you will get cervical cancer. Okay, cigarette smoking, exposure to diethylstilbestol with a non-steroidal estrogen which prevents pregnancy. Okay, clinical features of cervical cancer. If the cervical cancer is early, there will be abnormal vaginal bleeding, abnormal vaginal discharge, dys- dyspareunia, and pelvic pain. Okay, pelvic pain. Now, abnormal vaginal bleeding will be postcoital spotting. One of the examples are postcoital spotting, which is like after sex, there will be spotting seen. Abnormal vaginal discharge, burning pain is called dyspareunia. Okay, now late is hydronephrosis. Late symptoms are hydronephrosis, lymphedema, and fistula formation. Hydronephrosis, lymphedema, and fistula formation. Okay, now staging of cervical cancer is done by physical examination, MRI, tumor size, lymphatic invasion, extrauterine extension, lymph node metastasis. Okay, so these procedures are used to stage the tumor. This is not the exact staging of the tumor. Then diagnosis. How do you diagnose cervical cancer? Diagnosis. First of all, pap smear, cervical cytology, then HPV DNA testing by PCR. Then you have colposcopy, colposcopy, and cervical biopsy. Again, pap smear, cervical cytology, pap smear, HPV DNA testing, colposcopy, and cervical biopsy. Okay, pap smear will be checking cervical cytology. HPV DNA testing is done by PCR. Colposcopy is something like endoscopy, like a camera tube inside the vagina to see the uterus and other cervix. Cervical biopsy is when, I think, by conization you remove it. Yeah, loop excision, conization, you remove it, and you can also biopsy that sample. Test that sample. Okay, now we will do treatment. Treatment is a small lesion. For small lesion, treatment is loop excision, conization. Even after the loop excision, pregnancy is possible. Hysterectomy, removing of uterus with parametria, like stuff around the metrium, the uterus, and pelvic lymphadenectomy. So pelvic lymph node is also removed. So first you have, if it's a small lesion, then you will have loop excision, conization, and pregnancy will still be possible. But the other treatment is hysterectomy, which will remove the uterus and the parametria and the pelvic lymph nodes. Sentinel lymph node biopsy is also done as treatment. And then you have, for large tumors, you have neoadjuvant chemo and radiation. Okay, neoadjuvant chemo and radiation. Now, precursor lesions of cervical cancer. There are three main precursor lesions. L-cell is for low-grade squamous intraepithelial lesion. H-cell is high-grade squamous intraepithelial lesion. And AIS is adenocarcinoma in situ. L-cell, low-grade squamous intraepithelial lesion. H-cell, high-grade squamous intraepithelial lesion. AIS is adenocarcinoma in situ. Okay. Now let's quickly see the types of cervical cancers. But let's go to the classification first. So you have squamous cell carcinoma, okay, and then you have adenocarcinoma of cervix. Adenocarcinoma in situ is the precursor lesion. Endocervical, mucinous, and intestinal are HPV dependent. These are the three types of adenocarcinomas of the cervix: endocervical, mucinous, and intestinal. Gastric type is the fourth type, which is not related to HPV. It can happen without HPV infection and it has the worst prognosis. Okay. Then you have endometrioid carcinoma. Clear cell carcinoma is clear cytoplasm and Hobnell cells. This is what you will see microscopically. Small cell carcinoma is neuroendocrine. Mesonephric adenocarcinoma, these are all types of cervical cancers. Mesonephric adenocarcinoma is from the mesonephric duct during development. Okay. Then you have secondary metastasis, direct invasion from the colorectum, urinary bladder, and uterine body. Okay. The transformation zone is where it's between the junction of squamous and glandular epithelium. Okay, and macroscopically it looks like a polypoid ulcerated mass. Okay, it looks like a polypoid ulcerated mass. Fine. We go back up. So we go to the first type of cervical cancer, squamous cell carcinoma. It develops in the metaplastic squamous epithelium. Develops from metaplastic squamous epithelium. Metaplastic epithelium is easily infected by HPV. Okay. Now the two precursor lesions, L-cell, low risk HPV stains. It happens because of low risk HPV. And histologically, it is similar to cervical intraepithelial neoplasia 1. Cervical intraepithelial neoplasia 1. Okay. L-cell. Histologically, it is equivalent to CIN1, CIN1, which is cervical intraepithelial neoplasia 1. Lower 1/3 is going to look like this. It will have a metaplastic squamous epithelium. Upper 1/3 will have coeliocytes. Okay. Now H cell. Let's do it with a different color. H cell. H cell is high risk HPV stains. Histologically, CIN2 or 3. It's a high grade dysplasia strongly stained by P16. If anything is stained by P16, means that it is positive HPV. This happened because there was HPV. If it is negative, if it doesn't get stained by P16, then it is negative HPV. It was not because of HPV. Okay, now invasive squamous cell carcinoma is well differentiated. Okay, causes because of well differentiated, it has keratinization. The well differentiated ones have keratinization. Poorly differentiated ones are basaloid. They look like basal cells. That's why basal cell carcinoma. Small cells resembling basal cell carcinoma. Stains strongly with P16. Squamous cell carcinoma not linked to HPV is P16 negative. So if someone has squamous cell carcinoma and it is not because of HPV, then it is the P16 is negative. Okay. Now the other type of cancer that we studied during the classification was adenocarcinoma of the cervix. Now the incidence of this cancer is increasing. The high risk HPV stains are 16, 18 and 45. 16, 18, 45. Okay. Exophytic bleeding masses. So the masses are like coming out, protruding, I think, and they are bleeding. Precursor lesions of adenocarcinoma of cervix is adenocarcinoma in situ. The epithelium of the endocervical glands, deep and extensive, hard to detect. Okay, so you have epithelium of endocervical glands. The lesions are really deep and they're hard to detect because they are inside the epithelium. So, okay, now another type of adenocarcinoma. Invasive adenocarcinoma. AC is adenocarcinoma. NOS means not otherwise specified. So you don't, it is an adenocarcinoma, but you don't know where you will put it. It is invasive tubular as in the shape of the gland is tubular, and cribiform, that's the shape of the gland as well. So it's invasive and it is either tubular looking or cribiform looking. Gastric type is an Asian woman. Asian women have gastric type, not HPV related, has bad prognosis. Not HPV related, sorry, HP gastric type of invasive adenocarcinoma is not related to HPV. So like it's not because of HPV infection, and the prognosis of the gastric type is really bad. Okay, there are four types of gastric. There are four types of invasive adenocarcinoma: signet ring carcinoma, intestinal carcinoma, clear cell carcinoma, and viloglandular. So you have signet ring adenocarcinoma, intestinal adenocarcinoma, clear cell adenocarcinoma, and viloglandular adenocarcinoma, and they are all invasive. Okay, so we are done with cervical cancer.